So a pleasure to be here today, and thanks to Douglas Mendez and Dr. Fajardo and Antigua and Moran for leading this group, which I've had the pleasure of addressing more than once, and hope to continue our relationship in participating in the education and care of folks in Northern Manhattan. And thanks, of course, also to Priscilla and Nancy for organizing this and doing such a great job. And thanks again to all of you for coming on this Sunday morning. So I'm going to talk, you just heard Dr. Andrews talk about ALS, and which is 20,000 people in the United States. I'm going to talk about disorders that have about the same, that are also infrequent. Usually I talk about Alzheimer's or Lewy body or frontotemporal dementia, or things that are much more common. Today we're going to talk about the rapidly progressive dementias. And I'm going to focus on two particular disorders, one of which is even worse, if you can believe it, than the one Dr. Andrews was talking about. Much worse than ALS, much faster, much more devastating, and no treatments at all. But still we should recognize it. And the other looks just as bad, but it's much, much better. We can treat it completely, and very often people are back to school, back to work, and completely normal after looking completely near dead. So I'll talk about these rapidly progressive dementias, from the sacred to the profane. And let's see if we can make this work here. I have disclosures also. I am a consultant for a couple of different organizations and get research grant support from a large number of pharmaceutical companies. But like Dr. Andrews, my talk today should not really involve any of those efforts. So I want to talk to you about the rapidly progressive dementias. And typically, these are disorders where the first thing that people notice is something very, very subtle. They may be tripping over their foot, like Dr. Andrews mentioned, or slowness, or fatigue, or insomnia, or inattention, or weird perceptual changes, looking at something on the street and not seeing it right, thinking you see a plate on the street outside. Of course, it's true if there's some plate on the street outside, there's many plates. Headaches, seizures, things that we don't think of as being of any particular import necessarily, at least neurologists don't think, but it can start like that and then snowball into something very bad over a period of weeks and months. So this is obviously a scary thing, and sometimes it is indeed something that reflects a very, very untreatable disease, and other times it reflects treatable diseases. So the first question we have with the rapidly progressive dementias, are they really rapid? Because this comes up a lot. I know that many of you are in practice, or many of you, sometimes some of you may even be in emergency areas, but certainly in practice you get the story all the time, whether it's a kidney problem or a brain problem. Yeah, it just happened overnight. She was perfect yesterday, right? Well, he was perfect yesterday. Everyone thinks that everything's overnight, or not everyone thinks, but many people perceive that problems have happened very quickly when they haven't really. So sometimes a chronic illness will have apparent rapid acceleration, whether it's heart, kidney, or brain. Sometimes the history is not correctly provided by the informant, something I'm afraid you're all familiar with. Sometimes it's a new informant who just came from Santo Domingo and hasn't seen the patient for 5 years. They say, he's completely different. And of course, it may not be that he's completely different from what he was some weeks or months or years ago. It's just he's completely different than 10 years ago. Then events may cause the appearance of rapid decline. Sometimes a person does very well because they have a partner or a home health aide or a supportive building taking care of them. And when that falls out, it suddenly becomes apparent how badly they were doing. Sometimes they're precipitating events, psychological stresses, deaths, or losses of jobs or homes, construction in northern Manhattan. And sometimes there's concomitant illnesses. Obviously, the most classic one is urinary tract infections and pneumonias, which may tip somebody over who is doing reasonably well. So there are a lot of ways in which something can appear rapid and not really be rapid. But of course, I'm going to talk to you about the ones that really are rapid. I know you're all going to figure out whether they're really rapid or not, usually anyway. Most of us try. So what are the rapidly progressive conditions? Well, the one that we fear the most is prion diseases, or Creutzfeldt-Jakob disease being the most common of those uncommon disorders. There's also CNS infections. Herpes is the most, probably the most common one of these uncommon disorders in the US. Of course, in other countries, unfortunately, rabies can be quite an issue, particularly in South America or Asia. And there's weird things like nuclearia. Some of you read about this poor guy who was in Texas, went to a water park and didn't survive it. It's an amoeba that unfortunately got into his brain. Rarely HIV can be a rapid infection, or SSPE, which is in the news right now because of all this measles. Unfortunately, measles can cause a rapidly progressive fatal brain infection. So there's the infections, there's the prion diseases, there's inflammatory disorders, which can go very fast. And there's the immune-mediated encephalitides, which are fascinating to people because sometimes those involve people who are even just children or babies or young women in the case of NMDA receptor encephalitis, or older people or people of all different ages and some of these others. Of course, today I don't have time in my remaining minutes to talk to you about all of these, so I'm going to focus on two things, two disorders. I'm going to focus on the prion diseases and tell you a little bit about CJD first, and then I'm going to focus on NMDA receptor encephalitis and the closely and the allied condition called potassium channel encephalitis. So the prion diseases are really fascinating to people. They're fascinating for a lot of reasons. I'll try to touch on them in the coming minutes. One reason they're fascinating is they can just occur out of the blue. They can be sporadic or idiopathic. They can also occur genetically. They can inherit them, unfortunately. And they can even be transmitted between humans. Fortunately, not easily, and we'll talk a little bit about that. What is CJD? Well, CJD is usually marked, most importantly, by rapidly progressive dementia. I'm going to show you a video in a moment where people explain that for a minute or so. But the dementia often is associated with myoclonus and ataxia. And those are the typical signs of CJD. Is rapidly progressive dementia, jerking movements, which is myoclonus, and ataxia, which is an abnormal gait. And there's all sorts of findings. I'm going to go through that a little bit. But typically the first signs are very subtle, like I mentioned before. But they become much less subtle as time goes on. So let's see if the video works. I've tried to embed it in a new way, so hopefully...
And that was all that we noticed. He ended up leaving my Mother's Day card at home, and he left clothes down there. And as we drove home, he got off on the wrong offering. And from that day on, every day he went downhill in some way.
So that's what it looks like at first. And it ultimately looks like this. Sorry.
During the course of CJD, virtually all
this is a individual obviously even more severely affected. He's getting feeding, or this myoclonus, you can see here.
Tract signs. Other symptoms, such as visual problems, seizures, and sensory abnormalities, are less common, and all symptoms may vary in their severity and time of onset. That variation appears to be related to individual differences.
Okay, we'll be back to the normal screen. I'll have some more videos later. Hopefully they'll be a little bit clearer. So you can see the flavor of CJD. It starts out very subtle, guy missing his exit to home, having other weird little things at home, problems at work, and then it can ultimately, with myoclonus and difficulty swallowing, speaking, moving, and maintaining one's posture. The EEG used to be a test we used. It's very nonspecific, doesn't help too much. You can see on the left side here, we have an EEG of somebody with CJD. On the right side of somebody with herpes simplex encephalitis. They look almost the same. Lumbar puncture is extremely valuable, but it's mostly valuable in the past because it allows us to say someone didn't have CJD. If they had cells, it wasn't CJD. It was one of these other disorders I'm going to try to talk about in the remaining minutes. But if they had no cells, of course, then we'd be concerned. Nowadays, we have more exacting tests. We have the RT Quick test, which is actually amazingly specific and sensitive for CJD. So lumbar puncture is absolutely key. Of course, spinal fluid examination, you all know, is absolutely key for all neurological diseases. And we do it for lots of people with Alzheimer's disease and Lewy body disease and everything else. I don't know why it got such a bad press. It got bad press because of neuromuscular disorders. Polio in the old days, people used to do spinal taps and people would get paralyzed. They thought it was the polio, they thought it was the spinal tap that paralyzed them instead of the polio. Terrible story. But in any account, spinal taps are very benign, as most of you know. It's less unpleasant for most people than a blood test. MRI is more unpleasant than a spinal tap. It's noisy, it's annoying, but it's very useful in CJD. We used to say it was normal, but it's not normal. It's true it's normal on T1 and T2 and a lot of things like that, but it's abnormal on fancier sequences. So it looks normal here, T1 images, but it's abnormal here. On the left, you can see that there's all that white stuff that's abnormal on the DWI image. On the right, you can see much more subtle examples of white stuff. If you look on the top panel, it's just a tiny little white thing at the rear of the brain. But then by some months later, it's really quite impressive, and there's a fair bit of white stuff all throughout the right side, which is on the left side of the brain that you're seeing in these areas here. But is the pointer working? Was the pointer working when I did that, or no? No? Yes? No. Okay. So, as I said, CJD starts out slow, and it gets worse and worse and worse. Unfortunately, it culminates in death. Brain biopsy is sometimes useful, but increasingly we don't have to do brain biopsy, which is somewhat invasive, because of the utility of spinal fluid and MRI findings. CJD is due to abnormal protein accumulation, just like Dr. Andrews was telling you about. Basically, this strange protein, the prion protein, that we don't even know what it does, gets all distorted and accumulates in a distorted conformation in the brain of the afflicted person. So I want to just go through a few other weird prion diseases because they're even more fascinating than CJD and more scary sometimes. There's the inherited prion diseases. About 10% of CJD is inherited. Very scary, just like the C9 issue that Dr. Andrews was talking about. These inherited disorders can come from mutations in a wide variety of places in the protein. And they look just like CJD often, although occasionally they last longer when they're inherited. So sometimes having inherited prion disease can mean you have a 10-year or 15-year course instead of a 6-month course. And there's Kuru, an acquired CJD. This poor lady on the left is being held up by her family members. On the right, you can see she's not even being well held up. She can't even stand. This was a disease that came from handling and consuming brain tissue in Papua New Guinea, something unfortunately we don't do here in our part of the world, and they don't do it there anymore either. The disease is fortunately gone, but it afflicted many people there. Obviously, there was one person who had CJD, and then the brain tissue got into supply and it became a propagating disease. We have an analog here in the Western world, which was dural transplants, human growth hormone and such. You may know people. Some of the people in those videos, a couple of the younger people, were people who had CJD from this mechanism. Fortunately, this is also gone. Just like the transmissible form in the Foray tribe in New Guinea is gone, because they're no longer doing ritual cannibalism. Similarly, we are very careful nowadays about what we transplant into people's brains. And we have E. coli to make lots of good proteins for us, so we don't need to get human growth hormone from pituitaries. What about variant CJD or mad cow disease? Well, everyone thinks that when somebody has CJD, it's mad cow disease, but it almost always is not, at least in the US. I don't have time to go through it in detail, but variant CJD is different. It affects younger people, not older people, and it does have something to do with cows, that is true. So I think I have the cows here. Yes, there's the cows. Those are mad cows, if you can't tell. They're not New York cows. New York cows are paradise. Okay, but regardless, it was an epidemic of mad cow disease, just like the problem with the Foray tribe in New Guinea, where some cow went bad and it got to be propagated because they were feeding cows in Britain, something which we didn't tend to do in North America, or the DR, of course. But they did it in Britain. They thought they were being very conservative. Shortly after the epidemic in cows, which affected some million or so cows, there was an epidemic in humans, which affected, unfortunately, a couple of hundred humans. The good news is that there was only 230 cases worldwide. Almost all of them were in the United Kingdom, that is Britain and its associated territories. There's only been a few in the US, and they were all from people who had been in the United Kingdom or the Middle East and gotten into contact with British cows. So we don't have much to do for prion disease. Unfortunately, it's a completely untreatable disease. The most important thing is to recognize it, because sometimes we see people come into the hospital who have something else going on, like a cancer or something else, and their symptoms are falsely misattributed to the prion disease, to the systemic disease, but they really have prion disease. So we certainly don't want to be fussing and doing lots and lots of investigation procedures for a disease that's going to kill somebody within weeks or months. And this is the biggest issue, unfortunately, with prion disease. Comfort measures are all we have. So now on to the other, I think we're running about 10 minutes behind, so I think I have about 10 minutes to tell you about immune-mediated encephalitides. And many of you are aware of this because there's this book, Brain on Fire. There's even a Netflix movie, Brain on Fire. I think you can see it there. There's trailers. Most of these are not the patient herself, but the actress who plays the patient, except in the far left, which I believe is the patient herself, who's a writer. What are the new immune-mediated encephalitides? Well, these are diseases that can look like CJD or these are rapidly progressive dementias. They start out insidious with minor things like headaches or seizures or tripping over your foot or not quite thinking right, and they can rapidly snowball to the point of people being unable to swallow, unable to think, unable to go and sometimes unable to breathe on their own, and then they may end up in the ICU. But these are treatable. There's a whole bunch of syndromes which we don't have time to talk about. There's the classic syndromes, and I'm going to talk to you mostly about the NMDA receptor antibody-associated encephalitis. Nowadays, we know that we can divide these immune-mediated encephalitis into two broad categories. The classic disorders that affect the proteins inside the nerve cells, kind of like the C9 that Dr. Andrews was talking about, and the more modern ones, if you will, such as the brain on fire disease, which affects the actual cell surface. And these are eminently treatable. These are inflammatory disorders caused by abnormal antibodies in the body. Sometimes they're cancer associated, but usually, more often than not, they're not. So what do you see on MRI? Well, you can all see these white spots in the middle of the brain. That is the limbic areas or the temporal lobes. The mesial temporal lobes, the hippocampi, are often inflamed. That can be particularly true in a related disorder called post-traumatic potassium channel encephalitis, which I'm going to just flip through here. The signs of that are not brain on fire signs. These are older people, and they tend to go and have memory problems first. But it's a very similar sort of thing. Memory problems, seizures, sometimes walking problems, and other problems. And I'm just going to flip through these because I do want to give Dr. Huey time to talk also. But the good news is that it's antibody associated. When we treat it, it can get better. Typically older people, sometimes cancer associated. So I'm going to go on to NMDA. NMDA was, both of these disorders, by the way, were discovered within the last 20 years. Both post-traumatic potassium channel and NMDA, both of which are members of a larger family of even more obscure and rarer disorders, which we won't have time to touch on today. So what does NMDA look like? Well, some of you have seen the Brain on Fire movie or read the book. It's not inaccurate. People start out with subtle symptoms. It's typically young women, often between the ages of 17 and 25, but it can affect infants as young as the first year of life, and can affect occasionally people over the age of 30, although that's fairly uncommon. This is just some pictures from some patients in Japan and the brain, and I'm going to try to do the videos again. Let's see, I think I should try to do the videos directly because it wasn't too successful when we did Dominican, this wasn't. So let's just show you 3 quick little videos. These are very short video segments. Well, that's loud enough. This is a 5-year-old, and I'm sorry they're partially undressed. You're not seeing it? Oh, you're not seeing it. Can you see it now? Okay. So I was saying, I'm sorry that the patient is partially undressed. In all 3 of these videos they are. It's not because they're trying to show off their lower extremities, but because these patients often are very hot. It's very hard to keep clothes on them. We're not going to get any clothes on people. It's from England. One of the disturbing aspects of this illness is that they often are practically naked in bed, in other words, distressed. other two. So you see there's abnormal movements, the person has a feeding tube, even more abnormal movements. So this young lady's a 13-year-old. She's able to go and talk. She's using her cell phone, sort of. She's kicking around, making no sense. Very distressing images. At any given time, we usually have about one of these in the hospital in Columbia. We get about 10 of them a year. Very distressing, very special families. The good part is that when they look completely demonic or possessed or brain on fire or whatever you want to say, it's eminently treatable. This is from England again. These are publicly available videos. See if I can get out of that. Go. I'll show the third one just for a moment. Maybe just for it's easy to see it. This is a younger child again. We originally didn't realize this could affect people under the age of 16, 17, but it does. And you can see how it can easily be confused with a variety of other disorders, but it's very rapidly progressive. That's what distinguishes it. Okay, so I'm going to finish up in the next few moments. The brain is sometimes abnormal, but not always abnormal on the MRI. Of course, it's always abnormal in its function. That's why you saw those horrific images. But it gets better, and you can see that here, the hippocampi aren't so great looking. Here, unfortunately, they got atrophic. They got damaged from the process. Other times, they look pretty good afterwards. Oh, you see my arrow? You still don't see my arrow. It's not working well. This computer is, yeah. Okay, so I think what I'd like to tell you is that in a fraction of these cases in young women, it's related to a tumor in the ovaries called a teratoma. Of course, if it's a man, it can't be related to a teratoma of the ovaries because they don't have ovaries. But it can be related to teratomas other places. We can see it very clearly that the antibody in the blood that's causing the problems binds to rat hippocampus on the left here and binds to teratoma on the right here. So apparently sometimes a tumor or sometimes just spontaneously an antibody can develop that causes the brain affliction. But it's amazingly specific for the hippocampus, isn't it? Look at that giant rat brain in the A panel on the left, and the only thing that's lighting up brown is the hippocampus formation. The disease can be very troublesome. While it is eminently treatable, it can go on for months and months and months. Some of these patients lose a year of their life, but the vast majority of them, at this point in time, do quite well, usually using a succession of treatments, including steroids, sometimes IVIG, often rituximab, and rarely plasmapheresis or cyclophosphamide. Just to give you an idea, this is sort of what the outcome measures are. This is the Rankin scale on the left. 6 is bad, that's death. 1 or 2 is good, is essentially minimal disability. And you can see that in the top panel on the left, we weren't so great at treating this like 10 years ago, but in the bottom panel on the left, we're really quite good. And the vast majority of people who have this disorder have little or no disability a year later. Or no disability a year later. It does matter a little bit about whether they have a tumor or not. When we take out a tumor, if they have a tumor, we take it out, they do a little bit better, but many people do not have tumors, and they do fine too. So that is how I'm going to finish up now, just about on time. Actually, I don't think I'm 4 minutes early according to this. So, but I wanted to go through then just about the myths associated with rapidly progressive dementias. So the first thing was the one we touched on, which you're all familiar with, which is that just because people say it's rapidly progressive doesn't mean it is rapidly progressive. The second thing is that the old CSF tests weren't so good for CJD. I can't tell you how many referrals I get of people who've had 1433 test and it was abnormal, and they thought, oh, it must have CJD, but they didn't. The third myth that I wanted to mention to you is that people who have CJD do not have mad cow disease in the US, except for unfortunate people who came from the Middle East or UK. We have not yet seen an endogenous case, that is a homegrown case of mad cow disease or ECJD in the United States, fortunately. Fourthly, it's a myth that the paraneoplastic panel in the cerebrospinal fluid is very useful. It isn't terribly useful. It's useful in the blood. The only antibody that really shows up in the CSF with any routine ability is the NMDA antibody, and it usually shows up in the blood as well nowadays. Another myth is that the immune-mediated encephalitides are paraneoplastic, that they're all cancer-associated. They are not, as I talked about briefly, alluded to a few times. Finally, people can have abnormal antibodies but not have active disease. So many of my patients who are perfectly normal and working and having kids, but who went through this, still have abnormal antibodies in their blood. But they're done with their disease. They just have these abnormal antibodies hanging out for some reason. It isn't bothering them anymore. Obviously, our treatment is what got them to where they were, we think, but the antibody doesn't necessarily correlate completely with disease. The disease deficits are not always reversible. Unfortunately, there were some people that rank in categories 5 and 6, people who do have a bad outcome. It's not, we can say that more often than not, people do very nicely, but we cannot say that they always do very nicely. Conversely, we can say that they don't have a poor prognosis, that in fact many people do very nicely. And with that, I'd like to finish up. And having told you about CJD, where people never do nicely, and they're rapidly progressive immune-mediated encephalitides, where often people can do quite nicely for many years and for lifespan. Thanks so much.
Thank you, Dr. Hani.